Okay, so lateral medullary syndrome is going to be a disruption of pica. So coming off the vertebral artery, which is positioned here in the pre-olivary sulcus, okay, you have pica coming off and supplying the lateral portion of the medulla, both left and right. And this is pica. Pica supplies the medulla with everything. I'll put my midline in here. Pica supplies everything that the vertebral artery didn't supply. So this is all pica. Put down here that left lateral medullary syndrome, Wallenberg's, is a disruption of pica. Okay, so if the inferior cerebellar peduncle is wiped out on one side, how would that patient present? Generally, what's the general term? Does anybody remember? Lack of coordination, ataxia. Okay, so this person's going to present with ataxia. They're going to be wobbly. Okay, nucleus ambiguous. If that's not there, what are they going to have trouble doing? Cranial nerve 9 and 10. Gag reflex. Swallowing. They're not going to be able to swallow. They're going to have swallowing difficulties. They may also present with a hoarse voice. H-O-A-R-S-E, I guess. Now, the spinal nucleus of trigeminal is affected. They're going to have sensory loss, right? Facial sensory loss, cranial nerve 5. STT is affected. They're going to have loss of crude touch, pain, and temperature. Here's the sympathetic tract. It's affected here on the left side. So they're going to present with left Horner's syndrome. That easy. And say that. Do you have a question, Ellie?
What was the last part again?
I don't know. Oh yeah. So if they don't have a functional sympathetic tract, they're going to present with Horner's syndrome on the left side. And this is lateral medullary syndrome. And there's a little saying: never pica, should be pick A, but I'll say pica for the artery. Small-eyed, disruption of disruption of the sympathetic tract. They have a constricted pupil. Hoarse, I'll even put H-O-A-R-S-E, that wobbles and can't swallow. So never pick a small-eyed horse that wobbles and he can't swallow. That takes care of a lot of the patient presentation for lateral medullary syndrome. Okay, and that's a problem with pica, ipsilaterally. Questions about that one? Yep, Ellie?
What was the inferior cerebral peduncle dysfunction again?
Ataxia. Ataxia. Yeah, these are all listed on the slides. We'll go through them in a minute. But hopefully, I mean, we've listed the functions of all these things. Hopefully, we'll come through. Yes, Alex?
Which nucleus was it that had taken away that didn't swallow?
Nucleus ambiguous. The little green one up there. Because that's going to be your cranial nerve 9 and 10. The two that are necessary to swallow. Any other questions? Okay. Moving on to medial pontine syndrome. Do you want the label? looking at the pons now. Talked about it before. This is going to be dorsal, and this is going to be ventral. Okay, cross section through the pons, and we have that nice landmark sitting there in the pons. It's going to be right here. What's the name of the part of the ventricular system in the pons? Anybody? That's your fourth ventricle. Okay. Again, always ventral, most ventral here. It's going to be your corticospinal tract. Kind of an elongated structure, always medial. Here's going to be your medial lemniscus. Okay. Thinking about, here's going to be that small little tract. Causes, that's your sympathetic tract, causes Horner syndrome. Okay, usually hanging around with the sympathetic tract close by is your STT. Spinal nucleus of trigeminal is this little kidney bean-shaped thing. Facial sensation or general sensory from the face. Okay. Thinking about way out here, we have vestibular and cochlear nuclei. So again, very medial, responsible for conjugate eye movements. It's going to be your MLF. And then we have a couple of cranial nerves to discern. The one that, so the cranial nerve that exits the brainstem or the pons most medially is going to be cranial nerve number 6. There's abducens nucleus, and here's cranial nerve number 6. Okay, and the one that's just lateral for cranial to the cranial nerve number 6 is going to be your facial nucleus. Facial nucleus sends out an axon that travels around cranial nerve number 6 and then exits ventrally. Okay, this is cranial nerve number 7. And then this is 6 here. Okay, that's a lot of them. Also thinking about, we can put in, here's a midline to help see left from right. Okay, in the very back of the pons here, you have your inferior cerebellar peduncle, left and right. going straight up, this is going to be your superior cerebellar peduncle. Okay, and on the outside, you're going to have your middle cerebellar peduncle. Okay. Okay, those are all the players. So everybody's labeled. So again, a review of all the structures we've labeled previously in the pons. As far as the medial pontine syndrome, we talked previously about the basilar artery coming straight up the middle of the pons here, and coming off the basilar. There are those small pontine arteries. Okay, it's the pontine arteries that are going to be responsible for supplying blood to the middle of the pons. So here's your midline, and the other area that it's going to supply is going to be very specific. There's actually going to be a split here between cranial nerve number 6 and cranial nerve number 7. It's going to come right through the middle. Okay, and then all of the area shaded is going to be affected on this left side. So, if the CST is gone, how's the patient going to present? Weakness, yeah. Weakness. And then it's going to be your job to figure out ipsilateral or contralateral, whether or not it's crossed over. Medial longitudinal fasciculus is gone. How does the patient present? Loss of vibration, proprioception, and fine touch. Okay. Cranial nerve number 6, the abducens nucleus is gone. Patient's going to present, yeah, with loss of the lateral rectus. Okay. And then if the medial longitudinal fasciculus is gone, they're going to have a disconjugate gaze. All these signs and symptoms are going to be very similar to the medial medullary syndrome. The only difference is the cranial nerve. So if the problems are all associated with cranial nerve 6, you know cranial nerve 6 is in the pons. 5, 6, 7, and 8 are in the pons. If all the symptoms are associated with cranial nerve 12 loss, then you know you're in the medulla. Yes, Alex?
Is the MLS reduced?
Yeah, it's that, it's the little, that.
But is it's being affected by?
Yes, it's most medial. Medial longitudinal fasciculus, very medial. It's medial lemniscus, all affected in any kind of medial syndrome, whether it's pontine, medullary, or even midbrain. Questions about that? Okay, so this is going to be a disruption of, let me write that down. This is a disruption of pontine. Okay? On one side. Medial pontine. And then let's do the same thing, but look at lateral pontine syndrome. So it's the same picture. We can just quickly go through and review naming all the little structures. Start with my fourth ventricle. Okay, labeling the front. The This is going to be ventral. This is going to be dorsal. Always most ventral. You're going to have your corticospinal tract. And then that elongated structure in the middle is going to be your medial lemniscus. And you have your sympathetic tract, little teeny tiny little tract. Usually somewhere around the sympathetic tract is going to be your STT. Kind of a kidney bean shaped nucleus here is the spinal nucleus of trigeminal. Okay, and then we have, there's vestibular and cochlear nuclei. Great, and then we have nuclei projecting out. Most medial is going to be cranial nerve number 6 with abducens. Just a little bit lateral is going to be cranial nerve number 7. That's the facial nucleus. So cranial 6, cranial nerve 7. And thinking about, here's the midline. Here's your medial longitudinal fasciculus, most medial. And then the rest are just cerebellar peduncles. So you have your inferior cerebellar peduncle most dorsally. Then you have your middle cerebellar peduncle taking up the lateral space. And then you have your superior cerebellar peduncle. Over there. Going up. Okay, we talked before that basilar artery is coming right up the center of the pons. And then coming off that basilar artery is going to be ICA. So there's ICA coming off, and ICA is going to be responsible for supplying the lateral portion of the pons with blood. Okay, and ICA's territory is going to be the lateral portion to whatever pontine artery supplied. So I'm going to make just a division here and say that everything lateral to this dotted line is going to be affected. You can think on the outside. Lateral pontine is disruption of AICA, A-I-C-A. Okay, so this person no longer has an STT. They're going to present with loss of pain, temperature, and crude touch. Loss of the sympathetic tract would result in Horner's syndrome. Loss of spinal nucleus of trigeminal. That would be loss of facial sensation. Loss of vestibular cochlear nucleus, so you'd have hearing problems. Remember in the last case we talked about the hearing problems associated with loss of the cochlear nucleus. You're also going to have vestibular nucleus, so vestibular problems and cochlear nucleus, as well as all this major conduit. So it's going to be both the the middle and superior cerebellar peduncles. So that person is going to present generally with ataxia. All that stuff on the outside. Okay, and a little mnemonic that goes with lateral pontine syndrome is with ataxia. Which is due to the loss of these peduncles here, and facial droop. Remember, you're going to have a facial droop due to the loss of the facial nucleus here. AICA is pooped. So, with ataxia and facial droop, AICA is pooped. That's with facial droop and ataxia. You should think AICA in the pons. Wish the cleaver. Questions about that? So if you can identify all the structures in between and know where the artery supplies, you're good to go. You can pick out patient symptoms. Okay, moving on. The last one, medial midbrain syndrome. And this one has its own name too. It's called Weber's syndrome. Okay. Here's my part of the ventricular system in the midbrain is going to be my cerebral aqueduct right there. Thinking about the big old cranial nerve that exits ventrally. There's going to be cranial nerve number 3, and here's the oculomotor nucleus. We talked before about these things called cerebral peduncles, and the cerebral peduncles are here. They're very ventral. They contain a combination of corticobulbar and corticospinal fibers. So those are your cerebral peduncles. So it's CST and corticobulbar. Okay. Other things would be looking at this elongated structure that's here in the middle. It's going to be your medial lemniscus. Okay. Also here medially is your MLF. Okay, you have your hanging around with your sympathetic tract. Here is your STT. Okay, and just above that, there's your sympathetic tract. And there's one nice landmark in the midbrain that has nothing to do with patient presentation, but that's going to be this structure here that we've talked about frequently, and this is going to be your red nucleus. It's in the midbrain. Okay, basilar artery comes up to the middle of the pons, and just above the level of the third cranial nerve branches off left and right into two shoots known as the PCA. Medial midbrain syndrome. If I draw in my midline here. Medial midbrain syndrome is going to be a combination of this basilar artery coming up as well as the PCA. Then you're going to have this area here be affected. So, combination of corticospinal and corticobulbar fibers are being affected. As far as patient presentation, you might expect to see weakness as well as facial droop. Okay. In addition to that, ocular motor nucleus has been affected. So you're going to see blown third cranial nerve. So most of extraocular eye muscles are gone, and you're also going to lose the Edinger-Westphal with that. Essentially, with a blown cranial nerve number 3, the eye is in a down and out position. Okay, so it's because the abducens is pulling it out, and it's more, and it's positioned laterally and depressed. Okay, it's called a down and out position. And since the medial longitudinal fasciculus has been affected here, you're also going to have a disconjugate gaze. Questions?